guys, in a patient. Yeah. Then on a peripheral blood smear, how to identify RBCs? First of all, the most abundant number of cells on a peripheral blood smear would be your RBCs, right? The most abundant number of cells would be your RBCs, first thing. Secondly, you can see these RBCs would be red in color, okay? The RBCs would be red in color, and these RBCs would have a central pallor, right? These RBCs will have a central pallor to them. And how much central pallor is there? So please remember, less than 1/3 central pallor is seen in a normal RBC. Less than 1/3 central pallor is seen in a normal RBC. If this central pallor increases, if there is more than 1/3 central pallor, or the RBC is appearing completely red, or if the RBC is appearing completely red, like in this condition of, for example, if I say, okay, such kind of RBC is seen, then it would be called as a spirocyte. Then it is called as a spirocyte. I hope all of you are quite aware of spirocyte. And please tell me, spirocytes in childhood are seen in which condition? Spirocytes in childhood are seen in, so please remember, spirocytes in childhood are seen in hereditary spirocytosis, whereas spirocytes in adulthood are seen in autoimmune hemolytic anemia, right? As we discussed already in the last class, spirocytes in childhood are seen in hereditary spirocytosis, whereas spirocytes in adulthood are a feature of autoimmune hemolytic anemia. Very good. Then if I talk about the shape of the RBCs, the normal shape of the RBCs is usually biconcave, right? The normal shape of the RBCs is usually biconcave. If there is some abnormal shape of RBC, like it is an elliptocyte or it can be a spirocyte, then definitely there would be destruction of these type of RBCs. If there is some defective shape, these type of RBCs would be destroyed in the spleen mainly, right? Therefore, spleen is considered as the graveyard of RBCs. Spleen is considered to be the graveyard of RBCs in a patient, right? So over here, after RBCs, if I talk about the smallest cells on a peripheral blood smear, and the smallest cell on a peripheral blood smear will be the platelets, right? The smallest cells on the peripheral blood smear would be the platelets. And what is the normal count of platelets? As we discussed in the last class, the normal count of platelets is between 1.5 to 4 lakh cells per cubic millimeter. Normal count of platelet is 1.5 to 4 lakh cells per cubic millimeter. And if there is deficiency of platelet, it is called as thrombocytopenia. Deficiency of platelets is called as thrombocytopenia. All of this I have discussed in the last class. I'm just giving you the basis. Now, apart from that, if I talk about the WBCs, the normal count of WBCs is 4,000 to 11,000. Normal count of WBCs is 4,000 to 11,000. WBCs can be of two types. Either these are agranulocyte, okay, agranulocytes which will not contain any kind of granules inside them, and these agranulocytes can be either monocytes or they can be lymphocytes. So agranulocytes are either monocytes or lymphocytes, whereas the other cells are called as granulocytes. Other cells are called as granulocytes, which will contain abundant granules in the cytoplasm. And these granulocytes are of three types. First is the neutrophil, second is the eosinophil, and third is the basophil. So how to identify these WBCs on a peripheral blood smear? So please remember, if you see a very large cell having a kidney-shaped nucleus, a very large blood cell having a kidney-shaped nucleus, then it is called as a monocyte. Large cell having a kidney-shaped large nucleus is known as a monocyte. So why I'm telling this? Because peripheral blood smear picture, they have asked you earlier also, they have just asked you to identify the normal blood cells, right? Next, you can see a blood cell having a very large nucleus, okay, which is circular. So a blood cell having a very large circular nucleus, it is actually called as the lymphocytes. It is called as the lymphocytes. So lymphocytes can either be B lymphocytes or it can be T lymphocytes, as all of us are quite aware. Then if I talk about the granulocytes now, in granulocytes, the most abundant ones are your neutrophils. So out of the total WBCs, 50 to 70% are your neutrophils. One question to you guys, a question was a one-liner previously. What is the half-life of neutrophils? What is the half-life of neutrophils? Please answer that in the chat box. So if I talk about the neutrophils, how to identify a neutrophil, definitely it will have multiple granules in the cytoplasm, first thing. Secondly, you can see there is a 3 to 5 lobe nucleus. There is a 3 to 5 lobed nucleus. So if there are 3 to 5 lobes in the nucleus of some WBC, that is definitely a neutrophil. So therefore, it is called as a segmented neutrophil, right? So 3 to 5 lobe nucleus is seen in a neutrophil. Then talking about the eosinophil are only 1 to 4% or 1 to 6% maximum, right? And these eosinophils can be identified by pinkish color granules in the cytoplasm. If a WBC has pinkish color granules in the cytoplasm along with a bilobed nucleus, then it is more likely to be a eosinophil. Bilobed nucleus along with pinkish color granules, it is definitely a eosinophil. Whereas talking about the least common cell, and that is 0 to 1% count, it is your basophils, right? Please remember, basophils will have how to differentiate it from lymphocyte. So this is actually a problem because lymphocytes as well as basophils, both of them have a very large circular nucleus. Both of them have a very large circular blue color nucleus. So how to differentiate? Here in lymphocyte, you can see there is no presence of any granules. Okay. So if granules are absent, it is more likely to be a lymphocyte. And if with a large nucleus, granules would be present throughout the cell. Granules present throughout the cell, even covering the nucleus. This is known as the basophil. This cell would be known as the basophil. Yes, half-life of neutrophils, guys. Please remember, half-life of RBCs, all of us are quite aware, it is 120 days. Normal half-life or lifespan of RBCs is usually 120 days. The lifespan of platelets is around 7 to 10 days. The lifespan of platelets is around 7 to 10 days. I am asking about neutrophils. This was a question which has been asked earlier. So that is the reason why I'm asking it to you. It is usually 6 to 12 hours. Very good. It is to be 6 to 12 hours. One answer to be given is 6 hours. Okay. One answer to be given is 6 hours in a patient. No issues with this. I hope so. Now we spoke about anemia also last time, right? So now we spoke about anemia. Anemia means decrease in the hemoglobin or maybe decrease in the RBC count. Both of these conditions would be considered as anemia in a patient, right? Decrease in hemoglobin or decrease in the RBC count is definitely considered as anemia. What is the normal hemoglobin concentration? So the normal hemoglobin count or the normal hemoglobin level in an adult male, it is 14 to 16 grams per deciliter. In adult male, it is 14 to 16 grams per deciliter. In an adult female, it is 13 to 15 grams per deciliter. Females made is 13 to 15 grams. Very good, Akshay. So therefore, the range would be 13 to 16 grams per deciliter. And we call it anemia when the hemoglobin level is less than 12 grams per deciliter. When the hemoglobin level is less than 12 grams per deciliter, we call it as anemia, right? As we discussed. But important, please remember, anemia usually in pregnancy is when hemoglobin level is less than 11 grams per deciliter. Very good. Anemia in pregnancy when hemoglobin level is less than 11 grams per deciliter. Whereas in Indian context, as the females usually have a normal hemoglobin, low hemoglobin count, therefore in Indian context in pregnancy, we consider anemia if the hemoglobin is less than 10 grams per deciliter. Very good. It is less than 10 grams per deciliter. Very good, all of you. Now, if I talk about anemia, I also need to talk about, apart from the hemoglobin and RBC count, I also need to talk about the other indices, and that is your MCV, that is your mean cell volume or mean corpuscular volume. And the normal MCV is 80 to 100 femtoliter. So the mean cell volume, it is nothing but the size of the RBC, right? And the normal MCV is 80 to 100 femtoliters. Whereas if I talk about the other ones, that is MCH and MCHC, these are the other two indices which are important. MCH is mean cell hemoglobin. Okay, mean cell hemoglobin, and the normal value of mean cell hemoglobin is 27 to 30 picogram. Normal value is 27 to 30 picogram. Whereas MCHC is mean cell hemoglobin concentration. MCHC is mean cell hemoglobin concentration, and normal value for this would be around 32 to 37 picograms. Normal value of MCHC is around 32 to 37 picograms. No issues with this. So it's definitely, if hemoglobin count decreases, definitely the color of the RBCs would be more pale, right? And therefore it is called as the hypochromic anemia. If the color of RBC decreases due to decrease in the hemoglobin concentration, it is called as hypochromic anemia. And if talking about the size now, depending on the size, we can also classify anemia. If the size of RBC is decreased less than 80 femtoliters, it is called as microcytic anemia. If the size of the RBC is increased more than 100 femtoliters, we will call it as macrocytic anemia. And if the size is between 80 to 100 femtoliters, we will call it as normocytic anemia, right? So if I talk about a condition where patient has anemia, hemoglobin RBC count is low, and the patient has MCV count which is low, okay, less than 80 femtoliters, whereas MCH and MCHC counts are also low. It is which type of anemia? Anybody? MCV is also low, less than 80 femtoliters, whereas MCH and MCHC both are low. So here definitely it is a microcytic hypochromic anemia. So here we are talking about microcytic hypochromic anemia. Microcytic hypochromic. And what the mnemonic I gave you last time? So the mnemonic to remember microcytic hypochromic anemia is Sita or Sital. You need to remember Sita or Sital, right? So S is for S is for Sideroblastic anemia. S is for Sideroblastic anemia. I is for the most common type of anemia, and the most common type of anemia is iron deficiency anemia. Iron deficiency anemia. T goes for a hemolytic anemia, and that is thalassemia. T for thalassemia. A for anemia of chronic disease. A for anemia of chronic disease. And L goes for lead poisoning, which is also called as plumbum. So lead or plumbum poisoning, right? So why you can even remember Sita also, because lead poisoning can lead to sideroblastic anemia in the patient. Okay? So all of these are causes of microcytic hypochromic anemia. Next, if I say, guys, please remember, if the patient's hemoglobin and RBC count is low, definitely anemia again. But this time his MCV is normal. That means it is between 80 to 100 femtoliters, whereas his MCH and MCHC both are normal. Okay, MCH as well as MCHC also both are normal. So this is definitely a normocytic normochromic anemia. This is a normocytic normochromic anemia. And the mnemonic which I gave you for that was ARC. Okay, the mnemonic for normocytic normochromic anemia is ARC, right? Where A goes for aplastic anemia. A goes for aplastic anemia. And I hope there was a recent question on aplastic anemia, so you know about aplastic anemia. Aplastic anemia mein kya hota hai? There is fat in the bone marrow. If there is fat in the bone marrow, the cells could not divide inside the bone marrow, and therefore there would be deficiency of all the blood cells. Okay, there would be anemia in the patient, there would be thrombocytopenia in the patient, as well as there is leukopenia in the patient. That means there would be pancytopenia. So in cases of aplastic anemia, the patient will have pancytopenia. Okay, so A goes for aplastic anemia, as well as A also goes for acute blood loss. So there was a query, acute blood loss. So please remember, what do we mean by acute blood loss? Whenever a patient had a road traffic accident, when he had a femur fracture or a pelvic fracture and a very huge blood loss, after that, if the patient is presenting to you on peripheral blood smear, the patient will have a normocytic normochromic anemia. So in cases of acute blood loss, definitely a NC anemia is seen. R goes for renal failure. R goes for renal failure. C goes for, now this is important, C goes for chronic disease. Okay, so you would say, sir, aapne chronic disease we also discussed in microcytic hypochromic, you are also telling it is a normocytic normochromic type of anemia. So please remember, yes, anemia of chronic disease, which is associated with multiple inflammatory conditions like inflammatory bowel disease, rheumatoid arthritis, SLE. In all these conditions, when a patient is having anemia of chronic disease, it can either be a normocytic normochromic anemia or a microcytic hypochromic anemia. Please tell me which is more common. In anemia of chronic disease, which type is more common? Is it the NCNC type, or it is the microcytic hypochromic type which is more common? And lastly, sorry, please let me know in the chat box, guys. Please tell me. And lastly, H goes for hemolytic anemia, guys. And lastly, H over here goes for hemolytic anemia, except for thalassemia. So please remember, thalassemia is not a normocytic normochromic anemia. Rather, thalassemia we discussed in microcytic hypochromic anemia. So all other hemolytic anemias are normocytic normochromic, except for one, and that is thalassemia, which is microcytic hypochromic. No, guys, please remember, this is important. Anemia of chronic disease, more commonly, it is normocytic normochromic. Anemia of chronic disease more commonly is normocytic normochromic type of anemia, and that was the reason I asked this question. I knew most of you would make mistakes, so please remember, it is normally a normocytic normochromic anemia more commonly as compared to microcytic hypochromic. Okay, please remember this, don't make a mistake. Whereas the last scenario is again a patient having anemia, low HB and low RBC count, but now this patient's MCV, that is mean cell volume, is more than 100 femtoliters. Okay, the mean cell volume is more than 100 femtoliters, whereas the MCH is normal, that is MCH or MCHC, both of these are normal. Definitely here it is a macrocytic normochromic anemia. It is a macrocytic normochromic anemia in this patient, right? Microcytic normochromic anemia. And the mnemonic that we discussed was LHMC, Lady Harding Medical College, right? LHMC, where L goes for liver diseases, L goes for liver diseases, H goes for hypothyroidism, H goes for hypothyroidism, M goes for the classical one, that is megaloblastic anemia, M goes for megaloblastic anemia, and lastly C goes for cytotoxic drugs. Okay, C goes for cytotoxic drugs. So some anti-cancer or cytotoxic drugs can cause macrocytic normochromic anemia. And from C also remember a cytotoxin, and that is alcohol. So alcohol intake also can lead to a macrocytic normochromic anemia. So alcoholics में किस type का anemia दिखता है? Macrocytic normochromic anemia. right? If I move further, guys, now talking about every type of anemia, let's discuss it. A patient presents with fatigue and generalized weakness. On examination, pallor is noted. So these are the three classical symptoms of anemia. Any type of anemia will present with these classical features. There would be fatigue in the patient, there would be generalized weakness, and there would be pallor, right? Along with that, they have also given a finding known as spoon-shaped nails. So this is a specific finding for a type of anemia. Spoon-shaped nails, as you can see over here in this image, here these spoon-shaped nails, they are called as koilonychia. The spoon-shaped nails are called as koilonychia. So this has been a question very commonly. Spoon-shaped nails is known as koilonychia, right? So koilonychia noted along with anemia features, and the peripheral smear is given in this patient. As you can see the peripheral smear in this patient, if I can just show you the peripheral smear, here you can see the RBCs over here, okay? The RBCs over here, they are usually smaller in size, okay? The RBCs over here are smaller in size, and the MCV would be low. MCV would be less than 80 femtoliters in this patient, and therefore this is a microcytic anemia. Therefore, it is a microcytic anemia. Secondly, you can see that the RBCs are having central pallor more than 1/3. The RBCs almost appear to be white, right? So the RBCs are not having good amount of hemoglobin. Therefore, it is considered a hypochromic anemia. If the central pallor is more, that means the RBCs are hypochromic in nature. So it is a microcytic hypochromic anemia. Along with that, this characteristic finding on the peripheral blood smear, here you can see elongated RBCs, and these elongated RBCs are actually called as your pencil cells. These elongated RBCs are called as your pencil cells. So these features, when you say, okay, so please remember these features when you see, that is the microcytic hypochromic anemia on a peripheral blood smear along with pencil shaped RBCs, and on nail finding there would be koilonychia or spoon shaped nails. Definitely the diagnosis over here is iron deficiency anemia. The diagnosis over here is iron deficiency anemia, and as we know, just let me change the size somewhat. Yeah, so the diagnosis is iron deficiency anemia. And as we know, in cases of iron deficiency anemia, it is the most common type of anemia. So if they ask you the most common type of anemia, it is definitely the iron deficiency anemia. It is also the most common type of nutritional anemia. So whatever is the question, the answer remains same, that is iron deficiency anemia. What is the most common cause of iron deficiency anemia? Anybody? So iron deficiency anemia can be due to multiple causes. It can also be due to menses. So this was a question from a lot of you. Sir, in menses, which kind of anemia is seen? Yes, in menses, during like menstrual cycles, what happened? There would be excessive blood loss. So if a patient is having excessive blood loss, like menorrhagia, so chronic menorrhagia or chronic blood loss in a patient would also lead to decrease in iron stores, and that can also cause iron deficiency anemia in a patient, but on a long term, not in short term. So long term menorrhagia in a patient can cause iron deficiency anemia, but the most common cause would be, so please remember, the most common cause of iron deficiency anemia is nutritional deficiency. The most common cause of iron deficiency anemia is decreased iron intake in food or nutritional deficiency of iron usually. Therefore, it is more common in developing countries. Okay, more common usually in developing countries like India. Okay, no issues with this. We have discussed about the symptoms. Classical symptoms, please remember, they would be fatigue, generalized weakness, and pallor. Classical symptoms of anemia. Right now, please tell me, what is the best investigation they have asked you? What is the best investigation for diagnosis of iron deficiency anemia? What is the best investigation for diagnosis of iron deficiency anemia? So definitely, if I do the workup of this patient or in lab investigation, as it is anemia, so hemoglobin levels would be low. Definitely the RBC count would be low. Peripheral blood smear will show microcytic hypochromic RBCs along with pencil shaped cells. Okay, all of these features are seen. MCV would be low because it is a microcytic anemia. MCH and MCHC both would be low because it is a hypochromic anemia. Apart from that, very good. But the best investigation out of all, we can also check for serum iron levels. Okay, serum iron levels would be low in this patient, right? But the best investigation of out of all is serum ferritin. The best investigation is serum ferritin. So if they ask you what is the investigation of choice for iron deficiency anemia, or what is the best or gold standard investigation for iron deficiency anemia, answer should be serum ferritin levels. And the serum ferritin levels in this patient would be low, definitely, right? So this is important to remember. And what is the treatment, guys? What is the treatment for iron deficiency anemia? So we will definitely give iron supplementation to the patient. Okay, definitely iron supplementation is given to the patient. But whether we prefer oral route or IV or IV route, we prefer oral route or IM or IV route. What do we prefer? Out of both, what do we prefer usually? No, please remember, guys, please remember, if a patient is having mild to moderate anemia, okay, so we will prefer oral route. Okay, usually we will prefer oral route. Why? Please remember, usually oral route and IV route or IM route has same bioavailability. Like out of the total iron, only 20 mg or like 20% would be absorbed, right? So the total bioavailability of iron is 20%, whether you give it orally or in injectable form. So it does not create any difference. And therefore, we will prefer a more safer route, whereas a non-invasive route, and that is oral, right? So please remember, we will give iron supplementation via oral route unless and until there is a contraindication. Okay, unless and until there is a contraindication, it might be a malabsorption syndrome. And what are the malabsorption syndromes which will affect iron absorption? Anybody? So that can also be a cause of iron deficiency anemia, the malabsorption syndromes which can affect iron absorption. So I hope all of you are quite aware that vitamin B12 is absorbed from the terminal ileum, folic acid is absorbed from the jejunum, whereas iron is absorbed from the duodenum. And very good, AFMG 1122. Okay, so please remember here, it is usually your celiac sprue, right? So celiac sprue or topical sprue, which will mainly involve the duodenum. Okay, so duodenum is the site for iron absorption. So if they ask you most common site of iron absorption, so please remember, it is a one liner that you need to remember. The most common site of iron absorption is definitely the duodenum. So any malabsorption syndrome or infection which will damage the duodenum will hamper or impair the iron absorption in the patient and can even cause iron deficiency anemia. So celiac sprue is a very important cause of iron deficiency anemia as well. So if there is contraindication, like if there is a malabsorption syndrome in the patient or something, some other causes, when the patient is seriously ill, okay, after postpartum hemorrhage or something like that, then definitely we can give IV or IM, and those are your ferrous fumarate, okay, ferrous dextrans can be given, okay. So all of that can be given, but oral supplementations that we have is usually ferrous sulfate, ferrous fumarate, okay, all of these. So ferrous sulfate and ferrous fumarate are the best ones that we use. Then important one liner again, which vitamin will increase the absorption of iron? So iron absorption requires acidic medium. Okay, iron absorption requires acidic medium. So which vitamin will increase the absorption of iron? Very good. This is a very important question, and therefore iron supplementations are given with which vitamin? That is vitamin C, also known as the ascorbic acid. Vitamin C, also known as the ascorbic acid. Very good, very good. So please remember, iron absorption is increased with vitamin C or ascorbic acid. Therefore, whenever you give iron supplements to some patient, you will ask to give lemon water with it. Okay, so that will increase the iron absorption. This is important one liner, guys, multiple times repeated. Now a last question to you guys. Okay, last two questions. Yeah, very good. Phytates and oxalate, on the other hand, will decrease the iron absorption. Phytates and oxalates. So with tea or coffee, iron supplements are to be avoided. Okay, with tea, coffee, iron supplements are to be avoided. They should not be given. Phytates and oxalates will decrease or hamper the iron absorption. Very good. Now, two important questions I need to ask. First, if a child is presenting with iron deficiency anemia, he will be seen eating like soil or chalk or anything like that. Okay, non-nutritive substances. So that is called as what? If a child is having iron deficiency anemia, he is seen eating non-nutritive substances. This is a one-liner important one from pediatrics as well. And that is called as, very good, that is called as pica. When a child is eating non-nutritive food substances or non-nutritive substances, it is usually called as pica. And the last question, if we are giving iron supplementation to a patient, how do we assess the treatment response? What is the best parameter to assess the treatment response? Which is the best lab parameter to assess the treatment response? Because serum ferritin levels will take time to rise. So what is the best parameter to assess treatment response? These are all important one-liners. The best parameter to assess treatment response would be increase in the number of reticulocytes. Increase in the number of, no, TIBC would not be the best parameter. The best parameter is increase in the number of reticulocytes. Normal reticulocyte count is 1.5 to 2.5%. Okay, usually 0.5 to 1.5%, some of the books say. So it is the reticulocyte count which we will check for. Okay, so the best parameter to assess is reticulocytosis. Best parameter to assess iron deficiency treatment is reticulocytosis. Best parameter to assess iron deficiency treatment is reticulocytosis. So guys, please keep on repeating whatever I'm repeating once, twice, thrice. Okay, so that is how you will learn these things in the class itself. Okay, so best parameter is definitely reticulocytosis, increase in reticulocyte count. Then now moving further, guys, sorry, now talking about the next one. Here we have a picture of a peripheral blood smear again. Okay, and in this peripheral blood smear, if I can just zoom in for you. In this peripheral blood smear, you can see clearly that we have some RBCs which have some irregular projections on their surface. RBCs having irregular projections or irregular spikes on their surface are called as RBCs having irregular projections or spikes on the surface are called as anybody. So these type of RBCs are called as acanthocytes. These type of RBCs are called as acanthocytes, and acanthocytes are seen in, so irregular spikes on RBC surface are acanthocytes, and acanthocytes are seen in. Whereas if I can draw a picture where RBC is having regular spikes or regular projections on its surface, it would be called as echinocyte. It would be called as a echinocytes. Okay. So regular spikes on the surface, echinocytes. Irregular spikes on the surface, acanthocytes. Autoimmune hemolytic में दिख सकते हैं, but mainly acanthocytes are seen in a liver disease, and that is called as A-beta lipoproteinemia. Okay, please remember, acanthocytes are a feature of A-beta lipoproteinemia. Acanthocytes are seen in A-beta lipoproteinemia, whereas echinocytes are usually seen in renal failure. Okay, in renal failure, when there would be uremia in a patient, at that time we can see echinocytes on a peripheral blood smear. So guys, please remember, irregular spikes on RBC surface, acanthocytes, and acanthocytes are seen in A-beta lipoproteinemia, whereas regular spikes on RBC surface, echinocytes, and echinocytes are a feature of uremia or renal failure in a patient. Okay, don't forget this. Then talking about this picture over here, this peripheral blood smear, here you can see the RBCs are having bluish spots. Okay, these RBCs are having some bluish deposits. Okay, in a ring-like fashion. These bluish deposits can be seen in a ring-like fashion, and these are called as ring sideroblasts. Okay, if these bluish deposits are iron deposits, then these would be called as ring sideroblasts. These are called as ring sideroblasts. And on a peripheral blood smear, if we are able to see ring sideroblast, it is definitely a feature of sideroblastic anemia. It is definitely a feature of sideroblastic anemia. Right? Please remember. Sorry. Sideroblastic anemia, as we discussed, it can be due to lead poisoning. Definitely, sideroblastic anemia is usually due to lead poisoning in a patient. The other cause is drug intake. Some drugs can lead to sideroblastic anemia, which is the anti-tubercular drug causing sideroblastic anemia. So they would give you a history of a patient having TB, and he is taking or he started on anti-tubercular therapy, and now the peripheral blood smear shows ring sideroblasts. So such type of picture is suggestive of sideroblastic anemia. What is the anti-tubercular drug? Which is the anti-tubercular drug causing sideroblastic anemia? Please answer in the chat box. The anti-tubercular drug which causes sideroblastic anemia is definitely very good. It is isoniazid. It is isoniazid. Important. Okay? It is isoniazid. And one antibiotic drug which can cause it is chloramphenicol. And the other antibiotic drug which can cause sideroblastic anemia is chloramphenicol. No issues with this. Okay, please remember these two important causes of sideroblastic anemia. So what happens in sideroblastic anemia? Please remember, definitely the hemoglobin count would be low, the MCV count would be low in this patient. Therefore, it is a microcytic hypochromic anemia. So here you can say it is a microcytic hypochromic anemia in a patient, right? Whereas, sorry, if I talk about serum iron levels, okay, serum iron levels and serum ferritin levels, please tell me. As you can see, the iron deposits in these RBCs. That means in sideroblastic anemia, usually the iron levels are definitely high in this patient. There is no deficiency of iron as such. So please remember, serum iron would be high, as well as serum ferritin levels would also be high in cases of sideroblastic anemia. So this is the factor to differentiate it from iron deficiency. In iron deficiency, both these levels were low. In sideroblastic, serum iron as well as serum ferritin levels are high. Okay, so please remember, both of these are usually high. But what can happen? So these iron is actually not used properly, okay, for formation or synthesis of hemoglobin. So hemoglobin is not being formed, though iron is there in excess, but hemoglobin is not formed, and therefore there is a hypochromic anemia in this patient, right? Because isoniazid will inhibit the hemoglobin synthesis in a patient. Okay, the same mechanism is seen with all the other causes as well. Okay, now what is the stain used for sideroblastic anemia? What is the stain used for iron? Which is the stain? This is a one-liner from pathology. I hope all of you are quite aware. This is the integrated session, so I'll be covering every aspect of pathology, pharmacology, as well as medicine as well in hemat. Which is the stain used for iron. One liner, very important one liner, guys. Don't miss out on this. So for staining these iron deposits within the RBCs, we can use which stain? Very good. It is the Prussian blue stain. The stain used for iron is known as the Prussian blue stain. Stain used for iron is known as the Prussian blue stain. And on Prussian blue stain, which reaction is seen? Pearl's reaction is seen. These are important one-liners. Which reaction is seen with iron? It is the Pearl's reaction which is seen. Very good, Akshay. Not Alcian blue. Alcian blue, I'll discuss it. It is used for some other condition, right? Please remember, Prussian blue stain is used over here, and it is a Pearl's reaction. Important, okay? And on Prussian blue stain, when the iron deposits would be stained blue in color, then these type of RBCs or these type of RBCs having iron deposits all over, these are called as the Pappenheimer bodies. These are called as the Pappenheimer bodies. So please remember two important picture on peripheral blood smear. First is the ring sideroblast and second is Pappenheimer bodies. First is ring sideroblast and second is Pappenheimer bodies. Both of these are features of sideroblastic anemia in a patient, right? Now discussing about these, okay, just a minute. Now discussing about these conditions in the table, okay? Here we can compare them, all types of microcytic hypochromic anemia. If I can compare over here, you can see most common is iron deficiency anemia. Then we discussed anemia of chronic disease, sideroblastic anemia, and thalassemia. Okay, we will check for serum iron, serum ferritin, serum transferrin saturation, serum TIBC levels as well. At least these four are important to be remembered because they will help you differentiate. Okay, serum transferrin. Transferrin is a transport protein of iron, whereas ferritin is the storage form of iron. Ferritin is storage form, transferrin is transport form of iron. Okay, so if I check for iron deficiency anemia, definitely the serum iron levels would be low, serum ferritin levels would be low, therefore the transferrin saturation would be low. Whereas please remember, transferrin saturation and TIBC, total iron binding capacity, are always opposite to one another in almost all of the cases, right? So if serum transferrin saturation is low, so serum TIBC would be high in this patient. If I talk about sideroblastic anemia that we discussed now, here serum iron is high, serum ferritin is high, serum transferrin saturation. If iron is high, definitely transferrin saturation would be normal or increased again, whereas serum TIBC would be low in this patient. If I talk about thalassemia, as we discussed, it is a microcytic hypochromic anemia. Here, everything would be normal. So if it is a microcytic hypochromic anemia and everything seems to be normal, so definitely it is a thalassemia in the patient. Lastly, discuss about anemia of chronic disease. Guys, in anemia of chronic disease, as I told you, it is associated with multiple chronic illnesses like SLE or rheumatoid arthritis, inflammatory bowel disease, right? Chronic liver disease in a patient. So all of these can be causes of anemia of chronic disease. Here, as I told you, normocytic normochromic anemia is much more common as compared to microcytic hypochromic anemia in the patient, right? And if I tell you what is the cause behind this, so please remember, usually you can see the serum iron in this patient is low, but the serum ferritin is high. You would say how? So please remember what happens usually from the intestinal lumen, serum iron is definitely, so from intestinal lumen, iron is absorbed. Okay, from intestinal lumen, iron is absorbed in the intestinal cells with a transporter known as DMT1, dimetallotransferase 1. Whereas it is sent to the blood via this transporter known as ferroportin. It is sent into the blood via a transporter known as ferroportin. In anemia of chronic disease, what happens? Due to chronic inflammatory condition, the acute phase reactants would be elevated like ESR, CRP, fibrinogen, and one of the acute phase reactant is hepcidin. One of the acute phase reactant is hepcidin. So this hepcidin will inhibit this ferroportin. Okay, so hepcidin will inhibit this ferroportin. So iron is being absorbed into the intestinal cell, but not being transported to the blood because ferroportin has been inhibited, and ferroportin is inhibited by which protein? So ferroportin is usually inhibited by a protein known as hepcidin, which is usually seen in anemia of chronic disease. Okay, so therefore the serum ferritin or storage form of iron would be high, but this iron could not come out in the blood, and therefore the serum iron levels would be low. Okay, here serum transferrin saturations would be low, whereas TIBC would be low as well in this patient. Okay, please remember this. So this you need to remember at any cost, guys. Okay, so this is important to differentiate. Now talking about the last type of microcytic hypochromic anemia, or the first type of hemolytic anemia in a patient. So here they are saying A child was brought to the OPD. Okay, child was brought to the OPD with complaints of pallor and fatigue, classical symptoms of anemia. He has history of blood transfusion. Okay, so the child has history of blood transfusion. So please remember, usually normally anemia mein, mild to moderate anemia mein, blood transfusion is not required. Blood transfusion is required when hemoglobin level falls below 7 grams per deciliter. Okay, when hemoglobin is less than 7 grams per deciliter, it is considered as severe anemia in a patient, and that time we give blood transfusion to the patient, not before that. Okay, so here he has a history of blood transfusion. Peripheral smear is given in the patient. And what is the gold standard test for confirmation of diagnosis? So first of all, let's come to a diagnosis. What is a provisional diagnosis in this condition? So classical symptoms of anemia in this patient. And if I check for the peripheral blood smear, here I can see two important things. First are these type of RBCs, which are called as teardrop RBCs. First are the teardrop RBCs, and teardrop RBCs are seen in two conditions. So teardrops RBCs are seen in thalassemia or myelofibrosis. Teardrop RBCs रट लो दो जगह पे. Teardrop RBCs are seen in two conditions: thalassemia and myelofibrosis. Myelofibrosis and thalassemia, right? Which type of RBCs are seen? Teardrop RBCs. And the classical finding of thalassemia, what is over here? You can see these kind of cells. These are known as the target RBCs or the target cells. Okay, so here you can see the target RBCs or the target cells, right? So target RBCs or target cells are the classical feature on a peripheral blood smear of thalassemia. So definitely here the more likely diagnosis in this condition is definitely thalassemia. The more likely diagnosis over here is thalassemia. Now talking about thalassemia, guys, it is a hemolytic anemia. What do we mean by hemolytic anemia? That means RBC destruction is going on. Okay, so excess of RBC destruction is going on in the spleen. That means there is an extravascular hemolysis in the patient. Okay, there would be extravascular hemolysis in the patient. If there is extravascular hemolysis in the patient, definitely what will happen? There would be splenomegaly, because destruction of RBCs is the function of spleen. So if there is excess amount of destruction of RBCs, definitely the patient will have splenomegaly. The patient will have splenomegaly in the patient, right? There would be splenohepatomegaly. Why would I write splenohepatomegaly? Because please remember, whenever there is destruction of RBCs, on the other hand, there would be a compensatory RBC production also. On the other hand, there would be compensatory RBC production. So here, the spleen is destroying RBCs, whereas liver and spleen both are producing RBCs as well. Okay, liver and spleen both are producing RBCs. That is the reason why I write splenohepatomegaly and not hepatosplenomegaly. The classical finding is hepatosplenomegaly, right? But here I am writing spleen first. That means spleen is massively enlarged as compared to the liver. Spleen is massively enlarged as compared to the liver in cases of thalassemia. So two conditions of splenohepatomegaly, again, you need to remember the same ones that you remembered for teardrop RBCs. Splenohepatomegaly again in thalassemia and myelofibrosis. So thalassemia and myelofibrosis in a patient. Okay? Apart from that, this RBC production, excess of RBC compensatory production, will also occur in the bone marrow, and therefore there would be a bone marrow expansion. Okay, these bone marrow expansion, I hope all of you are quite aware. Usually RBC production occurs in the skull bones, in the sternum, in the clavicle. Okay, and after 18 years of age, it is predominantly taken over by the flat bones. Okay, but before that, it usually occurs in the skull bone, the sternum, the clavicle. Okay, so here definitely if there is bone marrow expansion due to excess of production, there would be frontal bossing in this patient, and there would be a predominance of the maxillary bones. Okay, so there would be bossing of the maxillary bones as well as bossing of the frontal bone. Along with that, there would be crowding of the upper teeth, and a pinched nose is seen. And this is the characteristic feature of thalassemia. What is this feces called as, anybody? These feces are called as, characteristic name they have. These feces are actually called as the chipmunk feces. These feces are called as the chipmunk feces. Very good. So chipmunk feces in a patient, whereas on abdominal palpation, there would be splenohepatomegaly and peripheral blood smear showing target RBCs or teardrop cells. Definitely the diagnosis is confirmed to be thalassemia in the patient. And if I talk about the skull X-ray in this patient, okay, so definitely the skull bones are overworking. Okay, they are working overtime. So now what can happen? I can just zoom in for you. Okay, what will happen? The trabeculations of the skull bones would be very much prominent. Okay, the trabeculations of the skull bones would be very much predominant in this patient, and therefore, just a minute, guys. Yeah, the trabeculations would be much more prominent, as you can see over here, and this is actually called as the hair on end appearance. Which appearance? Hair on end appearance, also known as the crew cut appearance, also known as the crew cut appearance. So please remember, in any type of hemolytic anemia, this appearance would be seen. Why? Because in any type of hemolytic anemia, if there is destruction of RBCs, there would be compensatory increase in production of RBCs also, and therefore on skull X-ray you can see this hair on end appearance or crew cut appearance. Okay, hair on end appearance or crew cut appearance. Urmila Thakur, please don't play with the screen. Okay, I just request you. So please let me know, guys, now. Okay, I am asking one or two questions about skull X-rays. Geographic skulls. Question number 1, you can just answer one, and what is your answer? Okay, geographic skull is seen in. Question 1, geographic skull is seen in. Question 2, raindrop skull is seen in. Question 2, raindrop skull is seen in. And question 3, pepper pot skull or salt and pepper skull is seen in. Please answer it. Okay, geographic skull, raindrop skull, and pepper pot skull. Important one-liners that you need to remember. Okay, 2, that is raindrop skull is definitely a feature of multiple myeloma. Very good. Raindrop skull in cases of multiple myeloma. Very good. Raindrop sabko pata hai. First one, geographic skull is a feature of anybody. Geographic skull is seen in cases of eosinophilic granuloma. Please remember, geographic skull is seen in cases of eosinophilic granuloma. Important. Okay, and whereas very good, very good. The third, that is your pepper pot skull or salt and pepper skull, is a feature of hyperparathyroidism, not hypo. It is hyperparathyroidism. Hypo nahi yaar, hyperparathyroidism. If parath hormone is high, that causes osteolytic lesions, not hypo. Okay, please remember this, hyperparathyroidism. Very good, very good. Okay, so talking about thalassemia, coming back to our question. So thalassemia, as we know, it is a defect in the globin chain production. Okay, it is a genetic mutation with the globin chain defect. I hope all of you are quite aware that hemoglobin is usually made up of heme plus globin chains, right? Just a minute, guys. I'm not sure if the pencil is charged. Yeah. Hemoglobin is usually made up of heme, and heme in turn is made up of iron plus protoporphyrin. Heme is made up of iron plus protoporphyrin, whereas we have 2 globin chains in the patient, total 4 globin chains in the patient, right? We have total 4 globin chains in the hemoglobin, right? And in adult hemoglobin, these are usually alpha 2, beta 2. Adult hemoglobin, mein these 4 chains are alpha 2, beta 2. Yes, in SLE, it can be seen sometimes. So jaldi se batao abhi. Now please tell me, which are embryonic hemoglobin? All of these are one-liners from pathology that whatever I am asking. What are the embryonic hemoglobin? The first hemoglobin to appear in a baby is. The first hemoglobin to appear in a baby is. No, before a fetal hemoglobin or HbF, which hemoglobin? No. HbF is a fetal hemoglobin, guys. It usually takes off from 14 weeks of intrauterine life. Before that, we have embryonic hemoglobins, and there are 3 embryonic hemoglobins. First is Gower 1. First is Gower 1. Second is Gower 2. And third is Portland hemoglobin. Again, I'm repeating the 3 embryonic hemoglobin. The first to appear is Gower 1. Second to appear is Gower 2. And third is Portland hemoglobin, right? Whereas after 14 weeks, usually definitely HbF takes over. That is your fetal hemoglobin takes over. And fetal hemoglobin is made up of which globin chains? It is made up of alpha 2, gamma 2. Fetal hemoglobin is made up of alpha 2, gamma 2. Whereas adult hemoglobin, okay? Whereas adult hemoglobin, HbA, it is made up of alpha 2, beta 2. I'll explain you about Bart's hemoglobin. Abhi discuss kar hi rahe, okay? Hemoglobin A or adult hemoglobin, which is almost 98% in an adult, it is alpha 2, beta 2. Whereas minor adult hemoglobin, that is HbA2, we call it as, okay? Minor adult hemoglobin, that is HbA2, it is alpha 2, delta 2. HbA2 is usually alpha 2, delta 2 in a patient. Okay? It is around 2.5 to 3.5% maximum of the total hemoglobin. Okay? Now, if I talk about thalassemia, we can have either the alpha globin gene or the beta globin gene. There can be mutation either in the alpha globin gene or in the beta globin gene. Jaldi se, alpha globin gene is located on chromosome number. Alpha globin gene is located on chromosome number, and beta globin gene is located on chromosome number. So alpha globin gene is located on chromosome number 16. Very good. Alpha globin gene on chromosome number 16. Retro. Alpha globin gene on chromosome number 16. Alpha globin gene on chromosome number 16. Whereas beta globin gene on chromosome number 11. Beta globin gene on chromosome number 11. Very good. So alpha globin gene has total 4 genes. Okay. So we have 4 genes for alpha. We have 4 genes for alpha and only 2 genes for beta. 4 genes for alpha and 2 genes for beta. So if I talk about beta thalassemia first, okay. The more common, if they ask you which is the more common type of thalassemia, answer would be beta thalassemia. The more common type of thalassemia in patient is beta thalassemia. So if I say If both the beta globin chains are absent, that means there would be 0% production. There would be 0% production of very good. There would be 0% production of beta globin genes. So this is called as thalassemia major. Right? And here the patient's life would be completely dependent on transfusion. So the patient over here will require multiple blood transfusions. Okay, so recurrent blood transfusions are usually required in a patient of thalassemia major when both the beta globin genes are absent. If I say if one of the beta globin gene is absent, one is present, one is absent, then it is called as anybody. One beta globin gene is absent and one beta globin gene is present. That means 50% production of beta globin chains is seen. So here the patient would have thalassemia. Here the patient will have thalassemia intermedia. Here it would be called as thalassemia intermedia. Please remember, guys, it is intermedia, not minor. Okay, it is called as thalassemia intermedia in a patient. एक major है इसका मतलब दूसरा minor नहीं होगा immediately. And if both of the beta globin chains are present, but there is partial presence. If both of the beta globin chains are present, but there is partial presence, and only 90% of beta globin chain production is normal, in this condition, it is called as thalassemia minor. Then it is called as thalassemia minor in the patient. No issues with this, anybody? So in thalassemia major, definitely the child would be brought to you if within 1 year of age. Okay, so an infant would be brought to you with features of anemia, and there would be all these chipmunk faces, splenohepatomegaly, crew cut appearance. Okay, all of these features would be seen along with features of CHF, congestive heart failure features can be seen because it is a very severe type of anemia. Hemoglobin less than 7 grams would be there. Thalassemia intermedia, this patient would require blood transfusion, but very occasionally. Okay, in our case, as they have given that the patient has a history of blood transfusion, so he might require only occasional blood transfusion and not a regular one. Okay. Whereas thalassemia major, this patient is completely asymptomatic and does not require any blood transfusion. If I talk about alpha globin chains or alpha thalassemia now, okay, so please remember there are total 4 alpha chains. Okay, there are total 4 alpha chains. If one of the alpha chain is absent, then the patient would have 75% production. So here the patient would be called as silent carrier. Okay, if 2 alpha chains are absent, that means 50% production is abnormal. So here it would be called as, jaldi se batao. Very good. Thalassemia trait in the patient. So if 2 alpha globin genes are absent, it is called as thalassemia trait. If 3 alpha globin genes are absent, then there would be production of Hbh hemoglobin. Then there would be production of a hemoglobin H, and it is called as hemoglobin H disease. Hbh disease. Whereas all of the alpha chains are absent, then definitely a gamma 4 tetramer is formed. And this gamma 4 tetramer if formed, then it leads to formation of a hemoglobin called as hemoglobin Barts. It leads to formation of a hemoglobin known as hemoglobin Barts. And please remember, hemoglobin Barts is nothing but a gamma 4 tetramer. And this hemoglobin Bart is incompatible with life. That means the fetus cannot survive if he is having hemoglobin Barts. And therefore, the patient will die due to a condition known as hydrops fetalis or erythroblastosis fetalis. The patient will die due to hydrops fetalis or erythroblastosis fetalis. So if they ask you non-immunogenic cause of hydrops fetalis, it would be alpha thalassemia in a patient, right? Whereas immunogenic cause of hydrops fetalis or erythroblastosis fetalis is RH incompatibility in the patient. Okay? No issues with this. So I'm done with this. Now, please tell me, coming to the diagnosis of thalassemia, apart from peripheral blood smear, we are still suspecting whether it is thalassemia or not in the patient. Okay. So for screening test, definitely I will do a Nestroff. That is naked eye single tube RBC osmotic fragility test. And on Nestroff, the osmotic fragility in thalassemia would be decreased. Okay. Osmotic fragility is decreased in thalassemia, whereas osmotic fragility is increased in hereditary spirocytosis. Osmotic fragility is decreased in thalassemia, whereas it is increased in hereditary spirocytosis in the patient. Okay, shabash. Jaldi se bata, what is the investigation of choice and what is the gold standard test which our question is asking you? So in Very good. The investigation of choice is HPLC, that is high performance liquid chromatography. Investigation of choice is HPLC or high performance liquid chromatography in the patient, followed by HB electrophoresis. If you don't have this an option, then definitely HB hemoglobin electrophoresis would be checked for. Menzer index is calculated. Okay, but please remember it would be high, but please remember it is not the investigation of choice. Investigation of choice is HPLC, high performance liquid chromatography, followed by HB electrophoresis. Whereas please remember, nowadays there was a question in the recent examination. HPLC was also an option, but the best test to be marked is, so if there is a genetic mutation, it would be best if you can see the genetic mutation itself, right? Or if you can see the gene itself. So you need to do gene sequencing. You need to do gene sequencing in the patient. So if they ask you the best test or the gold standard test, and if you have beta globin gene sequencing in the option, globin gene sequencing would be the best answer to be marked. Please remember this. This is an important question and most of them have missed it. Globin gene sequencing is the best answer to be marked for diagnosis of thalassemia. Okay, what is the best answer to be marked for thalassemia? Globin gene sequencing. What is the best answer? Globin gene sequencing. You can do it with a PCR, polymerase chain reaction, and that is the best answer to be marked for thalassemia in a patient. Okay. Okay, don't be adamant and don't be marked HPLC again. Okay, so it should be beta globin or alpha globin gene sequencing, because you can check the mutation itself and nothing better than that. Next, moving further, just tell me one important answer. Now, as thalassemia patient is requiring multiple and recurrent blood transfusion, therefore there would be a high risk of iron overload in this patient or iron toxicity in this patient. So what is the antidote of choice for iron toxicity or iron overload? Repeated question, Sarkari in my language. What is the antidote of choice? Very good. We can give a subcutaneous desferoxamine. We can give a subcutaneous desferoxamine or oral drug. Oral drug is what? Anybody? Oral drug I need. If they ask you what is the oral drug of choice for iron toxicity or iron overload, then your answer should be deferriprone. The oral drug should be deferriprone. The oral drug should be deferriprone. Okay, please remember this. Otherwise, it is desferoxamine, the best one, but it is injectable. So oral drug is deferriprone. Then next, guys, talking about other types of hemolytic anemia. So I will just, we were discussing hemolytic anemia. One we have discussed, that is thalassemia. So hemolytic anemia, guys, by the name itself, it is evident. That means there is destruction of RBCs in the spleen. Okay. If there is excessive destruction of RBCs in the spleen, it is called as extravascular hemolysis, right? So therefore, the patient will have splenomegaly in the patient, right? Therefore, we will have splenomegaly in the patient. Why? Because more and more number of RBCs are being destroyed. So spleen is working overtime. Again, to compensate this, we are having more and more RBC production also. Therefore, the patient will also have hepatomegaly. Okay, the liver is also working overtime. Along with that, now when hemoglobin is destroyed, what will happen? There would be production of heme, and therefore there will be production of bile pigments. There would be production of biliverdin and bilirubin. So which type of bilirubin is more? Here we will have indirect or unconjugated bilirubin, which is more. Okay, so therefore the patient will have unconjugated hyperbilirubinemia. What would be seen? Unconjugated hyperbilirubinemia. And if there is unconjugated jaundice in a patient or unconjugated hyperbilirubinemia, there would be a high risk of pigment gallstones. There would be a high risk of which type of gallstones? Pigment gallstones. So in cases of hemolytic anemia, which gallstones are much more common? It is the pigment gallstones which are common, because due to production of excess of bile pigments in the patient. So these are the things that you need to remember. And skull X-ray shows which appearance? So please remember, skull X-ray usually shows your hair on end appearance. Skull X-ray shows your hair on end appearance or crew cut appearance. No issues with this, anybody? Now talking about one more hemolytic anemia. Here, guys, I have a 2-year-old child coming to me. Okay, a 2-year-old child is coming to me with features of anemia. That means there is pallor, fatigue. On workup or investigation, there is low hemoglobin count, low RBC count. Okay. And on peripheral blood smear, this kind of a picture is seen. So here on peripheral blood smear, one thing that you can notice, that the size of RBCs is normal. Okay. Whereas the color of RBCs is almost normal, right? So here definitely it is a normocytic normochromic anemia. As we discussed, right? All hemolytic anemias are normocytic normochromic except for thalassemia. Thalassemia is microstatic hypochromic. Okay? So it is a normocytic normochromic anemia. Along with that, you can see the RBCs. Most of the RBCs are having completely red color. And these completely red RBCs which lack the central pallor, RBCs lacking central pallor are called as, normally RBCs should have 1/3 central pallor. These are normal RBCs. But if the RBCs are lacking the central pallor, that means these are called as spirocytes. These are called as spirocytes. So spirocytes on peripheral blood smear in childhood is usually suggestive of hereditary spirocytosis, whereas in adulthood it is suggestive of autoimmune hemolytic anemia. So definitely here my diagnosis would be hereditary spirocytosis in the patient. Hereditary spirocytosis in the patient, right? So as it is hemolytic anemia, definitely apart from these peripheral blood smear findings, normocytic normochromic anemia, and second feature is spirocytes. Apart from that, definitely the patient will have features of all these hemolytic anemia, unconjugated jaundice, hepatomegaly, splenomegaly, hair on end appearance, pigment gallstones, all of these. Now, please tell me hereditary spirocytosis. That means it is due to some genetic defect, and this genetic defect is usually in the RBC membrane proteins. The RBC membrane proteins usually maintain the shape of the RBCs. As we discussed, the normal shape of RBCs is biconcave. Normal shape of RBCs is biconcave. But here there is some defect in the RBC membrane protein, and therefore the shape of RBCs will turn spherical. Therefore, the shape of RBCs will turn spherical, or in hereditary elliptocytosis, it would be elliptical. In hereditary elliptocytosis is elliptical. Which is the most common protein defect in hereditary spirocytosis? One liner. Most common protein defect in hereditary spirocytosis. Please let me know. Most common protein defect in hereditary spirocytosis. Very good. Don't go by the name. There are multiple RBC membrane proteins like unchirin, spectrin, okay, band 4.2, pallidin. But the most common protein defect in hereditary spirocytosis is not spectrin, it is unchirin. Very good. Unchirin followed by spectrin. Whereas spectrin is the most common protein defect in which condition? Spectrin is the most common. Yeah, severe one would be spectrin, definitely. Severe one would be spectrin. Spectrin is a defect in which condition? Spectrin is a defect in hereditary elliptocytosis. Okay, spectrin is a defect in hereditary elliptocytosis in a patient. Very good, guys. Now, please tell me what is the investigation of choice? Apart from all these lab investigations that we did, peripheral blood smear we performed, what is the best investigation? We will check for proteins themselves, right? So definitely the best investigation that you have for hereditary spirocytosis is anybody? Protein electrophoresis. The best investigation is protein electrophoresis. On protein electrophoresis, you can check the values of these proteins, that is unchirin, spectrin, all of these, okay? And if there is deficiency of any of these, definitely it is suggestive of your hereditary spirocytosis in the patient. So best test would be protein electrophoresis in the patient. Okay, please remember. And what is the treatment of choice in this patient? Anybody? Jaldi se batao. What is the treatment of choice in hereditary spirocytosis in a patient? Treatment of choice. I'm taking almost all of the one-liners. Okay. What is the treatment of choice in hereditary spirocytosis? If we keep spleen in the patient, the RBCs will be kept on destroying. Very good. So it is elective splenectomy. Planned. Elective means planned, nothing else. Okay. So please remember it is splenectomy. So if they ask you what is the treatment of choice in a patient, definitely it is splenectomy, because you cannot do anything for the gene defect or the protein defect that is there. So the treatment of choice is elective splenectomy. And one more important one-liner: which vaccines are to be given 2 to 4 weeks prior to splenectomy? Which vaccines are to be given 2 to 4 weeks prior to splenectomy? Because after splenectomy, the patient would have a high risk of infection with capsulated organisms. Very good. We will give 3 vaccines. We give usually 3 vaccines. First is against the Streptococcus pneumoniae, that is pneumococcal conjugate vaccine. First is the pneumococcal conjugate vaccine. Second is against the Neisseria meningitidis, and against Neisseria meningitidis or meningococcus we have the meningococcal conjugate vaccine. Second is meningococcal conjugate vaccine. And what is the third one? Anybody? The third one is Haemophilus influenzae vaccine. Third one is Haemophilus influenza vaccine. At least remember these 3. एक याद रख के नहीं होगा. So PCV vaccine, MCV vaccine, and Haemophilus influenza vaccine. Some books also say influenza A vaccine can be given to the patient. Right? If I talk about these features, can anybody tell me a large bluish dot in the RBC is called as? A large bluish dot in this RBC. These are some bodies. These are usually seen in post-splenectomy patient. When spleen is removed in a patient, so post-splenectomy, these type of RBCs or these type of bodies are seen on a peripheral blood smear. These are not Heinz bodies. Yes, Heinz bodies can have bluish spot or orange color spot, but these would be seen in G6PD deficiency, not post-splenectomy. Very good. These are Howell-Jolly bodies. These are Howell-Jolly bodies. So please remember, post-splenectomy, which bodies are seen on peripheral smear? Howell-Jolly bodies. Post-splenectomy, which bodies are seen on peripheral smear? Howell-Jolly bodies. No issues with this? Now moving further. Now I have a 25-year-old adult patient, okay? Now I have a 25-year-old adult patient coming to me with same features of fatigue and pallor, that means anemia. On lab workup, hemoglobin is low, RBC is low. Peripheral blood smear was done, and peripheral blood smear again shows a normocytic normochromic anemia. Okay, it again shows a normocytic normochromic anemia. Along with that, again you can see these type of RBCs which are again lacking the central pallor. These RBCs which are almost lacking the central pallor. All these RBCs lacking the central pallor. And if RBCs are lacking central pallor, these are called as spirocytes. But spirocytes in adulthood, the common cause is autoimmune hemolytic anemia. The common cause for spirocytes in adulthood is autoimmune hemolytic anemia. Autoimmune hemolytic anemia. And what is this feature seen anybody? So please tell me, clumping of RBCs, or RBCs will get stick to each other. This is known as clumping of RBCs, condensation of RBCs. Okay, what is this feature called as? Anybody? On peripheral blood smear, when there is clumping of RBCs, this is called as, this feature is called as agglutination. This feature is called as agglutination. So there would be agglutination of RBCs. Sometimes it is also referred to as the Rolex formation. When RBCs will stack on one over the other, these would be called as the Rolex formation. So this was asked. Please remember, Rolex formation is a feature of. So Rolex formation is usually seen in cases of autoimmune hemolytic anemia. So when RBCs get stuck, this is called as agglutination or Rolex formation. So three peripheral blood smear features of autoimmune hemolytic anemia. First, normocytic normochromic anemia. Second, presence of spirocytes. And third, agglutination or Rolex formation. Now, autoimmune hemolytic anemia, by the name it is evident that some autoantibodies are formed which will destroy or damage the RBCs, and that is causing the anemia in this patient, right? So autoantibodies would be formed. These autoantibodies can be either warm antibodies or cold antibodies. Please remember, please give me the answer. Warm antibodies are which subtype? IgG, IgA, IgM, IgD or IgE? Warm antibodies and cold antibodies. Warm antibodies are which subtype? Anybody? Warm antibodies are which subtype usually? Please let me know. Very good. Warm antibodies. G for garam you need to remember. So warm antibodies are mainly IgG type. Warm antibodies are mainly IgG type. And warm antibodies की वजह से autoimmune hemolytic anemia is seen in conditions like systemic lupus erythematosus. SLE में दिखता है. Then in cases of chronic lymphocytic leukemia, in cases of CLL, okay, or in multiple other conditions also, we can see warm antibody induced autoimmune hemolytic anemia. Cold antibodies can be both. Cold antibodies can either be IgM type or they can be IgG type. If they are IgM type, okay, and both the causes, I'm just telling you the causes at once. Cold antibodies can be due to atypical pneumonia, and the most common cause of atypical pneumonia is Mycoplasma pneumonia. So that you need to remember at any cost. Mycoplasma pneumonia will produce these cold antibodies. Okay, so Mycoplasma pneumonia producing these cold antibodies can cause autoimmune hemolytic anemia in the patient. Apart from that, multiple viruses like your HIV virus, parvovirus B19, or influenza virus in some cases, okay, or Epstein-Barr virus, okay, all of these can be causes of cold antibody production and leading to autoimmune hemolytic anemia. So please tell me, IgM will lead to which syndrome? Anybody? IgM cold antibodies will lead to which syndrome? Sorry. IgM cold antibodies will cause. So please remember, IgM cold antibodies will lead to cold agglutinin syndrome. IgM cold antibodies will lead to cold agglutinin syndrome, right? So whenever there would be cold exposure, there would be clumping of RBCs and the patient will have increased symptoms or increased features usually. Whereas IgG type would lead to PCH, that is paroxysmal cold hemoglobinuria. IgG subtype will lead to paroxysmal, IgE can lead to Job syndrome. Very good. IgG subtype causes paroxysmal cold hemoglobinuria in a patient. Okay, PCH, paroxysmal cold hemoglobinuria in a patient. Again, on cold exposure, the symptoms of anemia usually increase in this patient, and that is what is a feature seen in autoimmune hemolytic anemia due to cold antibodies, right? So please tell me, Mycoplasma pneumonia, as we discussed, it causes production of the cold antibodies. This Mycoplasma leads to production of antibodies, and the name you need to remember, these are Donath-Landsteiner antibodies. Which antibodies are produced by Mycoplasma? Donath-Landsteiner antibodies. Which antibodies are produced by mycoplasma? Donath-Landsteiner antibodies. Okay, please remember. Now, please tell me what is the investigation of choice for autoimmune hemolytic anemia? Investigation of choice for autoimmune hemolytic anemia. Investigation of choice for autoimmune hemolytic anemia. Jaldi se. Investigation of choice for autoimmune hemolytic anemia. Very good. Which test? Direct Coombs test or indirect Coombs test? Direct or indirect Coombs test? This is important. They play with that. Very good. It is the direct Coombs test. Please remember, it is the direct Coombs test, which is the investigation of choice for autoimmune hemolytic anemia. Investigation of choice would be the direct Coombs test. Indirect Coombs test is done in RH incompatibility. Okay? And what is the treatment? As it is an autoimmune condition, definitely the treatment would be, the treatment in this condition would be, please remember, steroids. First line treatment would be steroids. Okay, if the patient is not responding to steroids, definitely we can give IVIGs to the patient. Definitely we can give IVIGs. And what with the final resort, final treatment of choice would be, if the patient is not responding to steroids, not responding to IVIGs, then the final one would be remove what? Which will destroy RBCs. So remove that organ, that is splenectomy. Shabash, kaat lo. Kiska? So please remember, it is usually splenectomy done. Okay, elective splenectomy is the last resort or last option in cases of autoimmune hemolytic anemia. Okay. Next, if I talk about this condition, here also we are talking about a hemolytic anemia. Again, a genetic condition having something like this picture on a peripheral blood smear. This kind of picture is usually seen. Okay, and what is seen over here? Half moon shaped or crescent shaped RBCs. Half moon shaped or crescent shaped RBCs are called as the sickle RBCs or the sickle cells. These are called as the sickle RBCs or the sickle cells in this patient. So if sickle RBCs are seen on peripheral blood smear of a patient, definitely the diagnosis would be sickle cell anemia. The diagnosis in this condition would be sickle cell anemia in the patient. The diagnosis is sickle cell anemia. As we know, sickle cell anemia is a hemolytic anemia. Okay, important, and it is again a normocytic normochromic anemia. In sickle cell anemia, there is some problem in the hemoglobin. Again, it is a hemoglobinopathy. And where is the problem? It is actually in the globin chain. Which globin chain? Alpha or beta globin chain? Jaldi. Where do we have problem in sickle cell anemia? Which globin chain? Alpha or beta globin chain? Fast, fast, fast. Which globin chain? Very good. It is the beta globin chain. Which globin chain? Beta globin chain. On which position? So we have problem in the beta globin chain. On which position? It is on the 6th position. On which position? So it is on the 6th position. So on the 6th position of beta globin chain, one amino acid is replaced by the other. That means glutamate goes and valine is welcome. Which goes? Glutamate goes and valine is welcome. That is how you remember it. Okay. So please remember, glutamate is replaced by valine in the 6th position of beta globin chain, and that causes sickle cell anemia in the patient, right? So now what will happen? Normally, if a patient is not having episode of sickling, so the peripheral blood smear would be absolutely normal. The peripheral blood smear in this patient would be absolutely normal in the patient, right? So if the patient is not having sickle shaped RBCs, the diagnosis would be difficult. So for that, we need to do a sickling test. We need to induce sickling. And when is sickling seen? So please remember, due to this, what happens due to this genetic mutation in the beta globin chain, this replacement of amino acid, abnormal hemoglobin is formed in this patient. Okay, and it is HbS. The abnormal hemoglobin formed as the sickle hemoglobin or the HbS. And what happens? What is the special property of HbS? So whenever the hemoglobin will donate oxygen, it will precipitate down in the RBC. And whenever it precipitates down in the RBC will change its shape to the sickle cell. Okay, the RBC will change its shape to half moon shaped or crescent shaped. Okay, no issues with this. So now that is the basic problem. If the RBCs are not undergoing sickling, we can we induce sickling in these RBCs. And what is the agent used? Important one-liners, guys. Previous year questions say I'm not asking anything irrelevant to the topic. Some points I'm just explaining to explain you the basis. These are all the one-liners that I'm asking you. Sickling test is induced by which chemical or which agent? Sickling test is induced by, this was a question. It is induced by sodium metabisulfate. It is induced by sodium metabisulfate. Please remember, the sickling agent which is used is sodium metabisulfate. or the other one is sodium dithionate. The other one is sodium dithionate. So two important chemicals that you need to remember, which will induce sickling in the RBCs, and that is sodium metabisulfate or sodium dithionate. They will cause deoxygenation of this hemoglobin, and therefore the RBCs will change a shape to sickle cell. Okay, no issues with this. Anybody now? Very good. Now, important thing that you need to remember about sickle cell anemia. Here, what will happen? These small RBCs, when they change their shape to sickle shape, they will get stick to each other. And whenever they will get stick to each other, they will block the small arteries. And whenever they will block the small arteries, they will cause painful vaso-occlusive crisis. They will lead to painful vaso-occlusive crisis. Depending on the blood vessels they will block, there would be different symptoms in the patient. Okay, and the patient will present to you in emergency with extreme pain. So painful vaso-occlusive crisis is seen. If the blood vessels of the fingers and toes are involved, if these are blocked, then definitely there would be inflammation of your fingers or inflammation of your toes and extreme pain in the toes of fingers. This is called as dactylitis. This is called as dactylitis. When there would be swelling and inflammation of your toes and fingers, this is called as dactylitis or the hand-foot syndrome If the coronary vessels are involved, if they ask you which is the most common painful vaso-occlusive crisis, the most common painful vaso-occlusive crisis, it is when the blood vessels of the coronary circulation or the lung blood vessels are occluded. There would be very excruciating chest pain in the patient, and the patient will present you with acute chest pain, and this is called as the acute chest syndrome. So the most common painful vaso-occlusive crisis is acute chest syndrome. The most common one is acute chest syndrome. Most common one is acute chest syndrome. Okay, so it will appear like MI, but it is usually due to the vaso-occlusive crisis and sickle cell anemia. Then there would be persistent painful penile erection lasting for more than 4 hours as well, if penile blood vessels are blocked, and that is called as, important question from surgery also in medicine as well. So painful persistent penile erection lasting for more than 4 hours is called as painful persistent penile erection lasting for more than 4 hours is called as, very good, priapism. It is called as priapism. It is called as priapism. Okay, that can also be one of the vaso-occlusive crisis in the patient. No issues with this. Now what can happen? The spleen is continuously it is destroying all these abnormal RBCs. It is working day in and day out, and if there is also blockade of the splenic vessels, there can be infarction of the spleen, and the patient on long term can have autosplenectomy. The patient on long term can have autosplenectomy. Yes, portal hypertension can also develop. Multiple features. Stroke can also develop. CVA भी हो सकता है in patients में, ठीक है? So this is important feature you need to remember. The spleen is damaged by the body itself. Therefore, it is called as autosplenectomy. ठीक है? So autosplenectomy is seen in which type of anemia? It is a feature of sickle cell anemia. It is a feature of sickle cell anemia. Now, please tell me, what is the investigation of choice? What is the investigation of choice, guys? Sorry. What is the investigation of choice? Anybody? Very good, very good, very good. All of you, please keep on answering, guys. Agar participate nahi karoge, then definitely it will not help you much. Okay, the investigation of choice is HPLC, that is high performance liquid chromatography. Investigation of choice is same as thalassemia, high performance liquid chromatography, or HPLC. Okay, important. Whereas the best investigation would be, if I ask you the best investigation, as I told you, if I will be able to see the genetic defect itself, that would be the best thing that I can do. So beta globin gene sequencing. No, Nestroft is a screening test, guys. Nestroft is a screening test for thalassemia. Nestroft is a screening test for hereditary spirocytosis, and it can also be used in cases of sickle cell anemia. But Nestroft would not be diagnostic in sickle cell anemia at all. Investigation of choice for thalassemia is HPLC. For sickle cell anemia also we can use HPLC. Here also we can use HPLC. But the best test for all of them, in thalassemia it is alpha or beta globin gene sequencing. For hereditary spirocytosis it is protein electrophoresis. Whereas over here also it is gene sequencing. Please remember, here also we can perform a gene sequencing. The best test, if they've asked you, or the gold standard test, it can be gene sequencing, where you can see the genetic defect itself via polymerase chain reaction. No issues with this, anybody? Now, what is the drug of choice? So if the patient presents to you in acute condition with acute painful vaso-occlusive crisis, definitely you will give IV analgesics to the patient to relieve the pain. So IV analgesics are given to the patient. Along with that, oxygen is given to the patient, and we will give IV fluids to the patient. That is, hydration of the patient would be done. So if the patient presents to you with painful vaso-occlusive crisis, IV analgesics, oxygenation, and IV fluids or hydration is required. But for chronic condition or for prevention or maintenance, what is the drug of choice? For prevention of sickling episode, so a drug which will convert the adult hemoglobin to fetal hemoglobin, and fetal hemoglobin will prevent sickling. Fetal hemoglobin will not let sickling occur. Why? Because fetal hemoglobin is alpha to gamma 2. Beta chains are not involved at all. So if fetal hemoglobin is there, HbS would not be formed, and HbS not there, so sickling would not be there, right? So for prevention, which is the drug? One liner, yaar. Drug, jaldi. The drug of choice for sickle cell anemia for prevention. Decitabine is a very new drug. It is hydroxyurea. Please remember the drug which is given is hydroxyurea in the patient, hydroxyu. And when the patient has severe anemia, okay, when a patient has severe sickle cell anemia, what should you give? You shall give packed RBCs to the patient, or you should give whole blood to the patient. So this is an important question. These clinical questions has been asked. Very good. You will only give whole blood transfusion to the patient. Why? Because please remember, if you give packed RBCs, there would be more and more destruction. So that is why you avoid, okay, giving whole PR packed RBCs. So whole blood is the best thing to be given in a patient of sickle cell anemia. Yes, they will rather increase the viscosity and worsen the symptoms. No issues with this. Anybody? Moving further, guys, talking about the next one now. Okay. Just a minute. So talking about the next one over here, we have this kind of a picture talking about macrocytic normochromic anemia now. Macrocytic normochromic anemia. And a macrocytic normochromic anemia would be if there is deficiency of some vitamins. Then we can see there would be this kind of a peripheral blood smear. And on this peripheral blood smear, you can clearly see there are very large RBCs, and these large RBCs are called as macrovalocytes. These large RBCs are called as macrovalocytes. Along with that, you can also see teardrop cells. So as I told you, teardrop cells are seen in thalassemia. They are seen in myelofibrosis. Okay, thalassemia, myelofibrosis, and the third place you need to remember is megaloblastic anemia. They are also a feature of megaloblastic anemia. And lastly, here you can see the neutrophils, but they are hyper segmented. So normal nucleus of neutrophil has 3 to 5 lobes. Okay, normal neutrophil nucleus has 3 to 5 lobes, but here the patient neutrophil would have more than equal to 5 lobes. Here the patient's neutrophil have more than equal to 5 lobes, and such type of neutrophils are called as hyper segmented neutrophils. So 3 features on peripheral blood smear. First is macrovalocytes, second is teardrop cells, and third is hyper segmented neutrophils in the patient. And there would be a macrocytic normochromic anemia. That means here the MCV of the patient, mean cell volume, would be more than 100 femtoliter. Mean cell volume would be more than 100 femtoliter, whereas the MCH or MCHC of this patient would be absolutely normal. MCH and MCHC of this patient would be absolutely normal. So macrocytic normochromic anemia over here, which we will see, it is a megaloblastic anemia. This is a megaloblastic anemia. And megaloblastic anemia, as I hope all of you are quite aware, it is due to deficiency of 2 vitamins. It is due to deficiency of vitamin B12, that is cobalamin, and vitamin B9, that is folate. Okay, so it is due to deficiency of vitamin B12, that is cobalamin, and vitamin B9, that is folate or folic acid. No issues with this. Now, vitamin B12 or B9 deficiencies can definitely be due to malabsorption syndrome. So ileocecal tuberculosis or any of the malabsorption syndrome affecting the ileum will cause malabsorption of vitamin B12. Okay, and if there is any malabsorption syndrome or any infection causing damage of the jejunum, that will cause deficiency of folic acid in the patient, right? Apart from that, folic acid deficiency is also seen in pregnancy or due to some anti-epileptic drugs, right? And therefore, a patient on anti-epileptic drug in pregnancy is at the high risk of having megaloblastic anemia. As well as, please remember, vitamin B12 can also be seen with a type of gastritis. Which type of gastritis and which type of anemia is seen? Please let me know in the comment. Okay, which type of gastritis and which type of anemia is seen due to vitamin B12 deficiency, isolated vitamin B12 deficiency? Please let me know. Okay, so here, just a minute, guys. Okay. So please let me know. Very good. It is type A gastritis which is the cause. Please remember, it is the type A gastritis or the autoimmune gastritis which is the cause of pernicious anemia, which is the cause of pernicious anemia, because type A or autoimmune gastritis will damage the parietal cells, and therefore there would be decreased amount of intrinsic factor of Castle, which is required for vitamin B12 absorption. Okay, it is required for vitamin B12 absorption. HCl would also be low. HCl would cause deficiency of which, there would be atrophic gastritis. Very good. So deficiency of HCl will lead to which type of anemia? Anybody? Deficiency of intrinsic factor causes vitamin B12 deficiency, but deficiency of HCl will cause which type of anemia? Anybody? We discussed this. Deficiency of HCl will lead to which type of anemia? Please let me know. So in type A gastritis, there can be megaloblastic anemia in the patient due to vitamin B12 deficiency, which is called as pernicious anemia. Whereas there can also be a microcytic hypochromic anemia in the patient. There can also be a microcytic hypochromic anemia in the patient. HCl, acidic medium, is required for absorption of iron. Therefore, the patient can also have iron deficiency anemia. Yaad rakh lena, okay? Just don't learn with vitamin B12. Patient can also have iron deficiency anemia due to deficiency of acid in the patient. No issues with this. Now, for diagnosis, a peripheral blood smear would be done. Definitely MCV, MCH concentrations would be checked. Apart from that, we need to confirm our diagnosis. So definitely we can check serum levels of both of these vitamins. We can check the serum levels of vitamin B12, cobalamin, or serum levels of vitamin B9, that is folic acid. Apart from that, there are we can also check for serum levels of homocysteine. Okay, we can also check for serum levels of homocysteine. So serum homocysteine levels would be elevated. Serum homocysteine levels are elevated in both the conditions. Whereas one important condition you need to remember, the two tests for vitamin B12 and vitamin B9 separately. Why vitamins are, please, I request you, vitamins are the most important. Last exam, 3 questions from vitamin B12 itself. Okay? So please remember, for vitamin B12, we have separate test. For vitamin B12 malabsorption, we can perform a test known as, for vitamin B12 malabsorption, we can perform a test known as well as we can also check the levels of methyl malonic acid. So in vitamin B12 deficiency, there would be elevated levels of methyl malonic acid. Along with that, we can perform a test known as, very good. So for malabsorption, we can perform a Schilling's test. For malabsorption, we can perform a Schilling's test. So Schilling's test is for malabsorption of vitamin B12. And which levels are checked? Methyl malonic acid levels are checked. Whereas if I talk about folic acid, for folic acid, the specific test is Figlu test. For folic acid, the specific test would be Figlu test. Okay? Learn these tests. These are important. Okay, please remember. Now, what will be the treatment of choice? Definitely, we will give supplementation to this patient. Okay, definitely we will give vitamin B12 and vitamin B9, that is folic acid supplementation. So vitamin B12 is given in injectable form, subcutaneous or IM, whereas vitamin B9 is usually given in oral tablet form. Okay, folic acid is given in oral tablet form. But here definitely, apart from anemia, as the patient is having deficiency of vitamin B12, the patient can also have features of peripheral neuropathy. The patient can also have features of peripheral neuropathy. Okay, so there can be some neurological symptoms like tingling, numbness, sensation loss, paresthesias usually. Okay, so peripheral neuropathy symptoms are also seen due to deficiency of vitamin B12. So for treatment, please remember, if you diagnose megaloblastic anemia, never give folic acid alone. This is also important question, and also for your clinical practice. Never give folic acid alone to the patient. Why? Because it will deteriorate the neurological symptoms of the patient. Okay, it will improve the anemia in the patient, but it will worsen the neurological status of the patient. It will worsen the neurological status of the patient. So for treatment, please remember, always give vitamin B12 as well as vitamin B9 unless and until you are very sure about the cause. Okay, so always treat the patient of megaloblastic anemia with both vitamin B12 as well as vitamin B9. Okay, important. Vitamin B12 deficiency can also lead to damage to the lateral and posterior spinothalamic tract, and that condition is known as, important, please tell me, vitamin B12 deficiency can also lead to a neurological condition which will damage the posterior and the lateral spinothalamic tract, and that condition is known as, important one-liner here, vitamin B12 ka. That condition is known as, please tell me, vitamin B12 deficiency can lead to damage of posterior and lateral corticospinal thalamic tracts, and that can lead to a condition known as, over here I'll write, okay, that will lead to subacute combined degeneration of spinal cord. That will cause subacute combined degeneration of spinal cord. Important, yeah, please remember, subacute combined degeneration of spinal cord is due to vitamin B12 deficiency. Important, okay, please remember this. Then Here, in cases of megaloblastic anemia, if the RBCs are being destroyed, again here also we can even perform splenectomy in some of the cases. Okay, so here you can see, again here you can see these type of rings are formed within the RBCs. 8-shaped rings or circular rings are formed in the RBCs, and these rings are called as Cabot rings. These rings are called as Cabot rings. So these are also seen on a peripheral blood smear of a post-splenectomy patient. These are also seen on a peripheral blood smear of a post-splenectomy patient or in cases of megaloblastic anemia. So Cabot rings on peripheral blood smear are seen in two conditions. They are seen in cases of megaloblastic anemia and secondly in post-splenectomy patients. Secondly in post-splenectomy patient. ठीक है? So post-splenectomy patient में we found out two important peripheral blood smear features. First was Howell-Jolly bodies. First was Howell-Jolly bodies, and second is Cabot rings. Second is Cabot rings. ठीक है? No issues with this, anybody? Now talking about this one, here you can see a supravital stain is used. Okay, a supravital stain like crystal violet, methylene blue, such kind of a supravital stain is used, and on a supravital stain there is bluish violet or orange color bodies can be seen. Depending on the stain that you use, you can see within the RBCs there are bluish color bodies or orange color bodies with the help of a supravital stain like methylene blue or crystal violet. And on peripheral blood smear, you can see such kind of a picture. On peripheral blood smear, such kind of a picture is seen. Okay, so these these bodies are called as Heinz bodies. These bodies are called as Heinz bodies. So whenever these Heinz bodies, they will pass via the spleen. Spleen will take bite of that. Okay, RBC. That part of the RBC would be taken a bite of, and therefore these cells which are formed are called as the bite cells. So peripheral blood smear pe bite cells or Heinz bodies are a feature of, both of these are a feature of G6PD deficiency. Yes, bite cells are also called as helmet cells. Bite cells can also be called as helmet cells. Okay, so bite cells, helmet cells, or Heinz bodies on a peripheral blood smear are definitely a feature of G6PD deficiency anemia. Both mostly they are a feature of G6PD deficiency anemia in the patient, right? Again, G6PD deficiency, that is glucose 6-phosphate dehydrogenase is an enzyme. Glucose 6-phosphate dehydrogenase is an enzyme used in which pathway? So please remember, if they ask you the most common enzyme deficiency worldwide, answer is G6PD deficiency. If they ask you most common enzyme deficiency worldwide, G6PD deficiency followed by pyruvate kinase deficiency. Biochem is important question. Most common enzyme deficiency worldwide is G6PD deficiency followed by pyruvate kinase deficiency. And if there is G6PD deficiency, that will cause hemolytic anemia in the patient, right? Very good. G6PD deficiency, G6PD, that is your glucose 6-phosphate dehydrogenase is an enzyme which is used in HMP pathway, hexose monophosphate shunt pathway. Okay, and in HMP pathway, as we are all sure that there is production of NADPH, and this NADPH is used for neutralization of the free radicals. This NADPH is used for neutralization of the free radicals. Okay, but if there is deficiency of G6PD enzyme, HMP pathway will not work, therefore NADPH is not produced, and therefore there is increased free radical injury or increased oxidative stress or oxidative damage of the RBCs. So there would be increased oxidative stress on RBCs, and that will cause hemolytic anemia in the patient of G6PD deficiency. What would be the triggers? Anybody? Two important triggers yaad rakhna hai. Two important triggers. If the patient consumes fava beans, that is important trigger. Okay, very good. If the patient consumes fava beans, and the second is if a patient was diagnosed with malaria and started with some drugs. Patient was diagnosed with Plasmodium vivax or ovale and started with primaquine-like drug, then definitely that is also a trigger factor to exacerbate anemia in this patient. So primaquine-like drugs. Okay, primaquine, chloroquine. Okay, so primaquine, chloroquine, these are the drugs, anti-malaria drugs, which can also trigger G6PD deficiency anemia in a patient, right? So please remember, which two are the triggers? These are your fava beans and anti-malaria drugs like primaquine and chloroquine or mefloquine-like drugs also. Okay, what is the investigation of choice? Anybody? What is the investigation of choice? Anybody? The investigation of choice is definitely check the enzyme levels. Definitely we will need to check the enzyme levels, that is G6PD assay or serum levels of G6PD. Okay, whatever you can have, serum levels of G6PD or G6PD assay is the investigation of choice for G6PD deficiency. And what is the treatment? Definitely you cannot give this enzyme from outside. At least we are trying for enzyme replacement therapies, but as such it is not effective for this. Gaucher's disease may we can give enzyme replacement therapy. Here we need to avoid the trigger in the patient. Okay, here we need to avoid the trigger in this patient. We need to avoid the trigger in the patient. Along with that, definitely if there is severe anemia, blood transfusion would be given to the patient. Okay, and if there is like a severe condition, if the patient is having a very severe anemia, then definitely in those conditions, what can be removed? Again, your spleen would be removed. Okay, what is removed? So the treatment of choice, if they ask you, the last resort would definitely be splenectomy. This last resort would be splenectomy in this patient. And after splenectomy, on peripheral blood smear, Howell Jolly bodies and Cabot rings would be seen. No issues with this, guys. Moving further with platelets now. As I told you, the normal value of platelets is 1.5 to 4 lakh cells per cubic millimeter. If they are usually less than 1 lakh cells per cubic millimeter, it is called as thrombocytopenia. Okay, less than 1 lakh cells per cubic millimeter is considered thrombocytopenia, but not severe enough. Okay, so if the platelet value would be less than 5,000 cells, okay, if the platelet value goes to less than 5,000 cells, that is the time for platelet transfusion. And what is given? Platelet concentrate is given. What is given? Platelet concentrate is given. Okay, so when the value of platelets falls below 5,000, that is the indication for platelet transfusion. But in cases of dengue hemorrhagic fever, as we know, thrombocytopenia is also seen in cases of dengue hemorrhagic fever. Over there, the cutoff is different. Okay, over there the cutoff would be less than 10,000. So if platelet count goes less than 10,000 in a dengue case, then that is the time for starting platelet transfusion. Then that is the time for starting platelet transfusion in the patient. Okay, that is the time for starting platelet transfusion in the patient. No issues with this, anybody now? Now we are having a case, a patient presents with epistaxis, that is nose bleeding, along with below given petechiae. Workup shows low platelet count. Diagnosis would be. So guys, not everything would be HSP, right? And why not HSP? I'll discuss it. Remember, we discussed HSP. HSP is an example of non-thrombocytopenic purpura. What do we mean by non-thrombocytopenic purpura? That means in cases of Henoch-Schönlein purpura, the platelet count is absolutely normal. The platelet count is absolutely normal. So please remember HSP. This is important. This is how you differentiate. Henoch-Schönlein purpura, where the platelet count is absolutely normal, and therefore it is an example of non-thrombocytopenic purpura. Okay? So here definitely if there is deficiency of platelets, platelet would lead to formation of the platelet plug or the clot. So if platelets are deficient, so platelet plugs would not be formed, and therefore the patient would have a higher risk of bleeding. There would be recurrent epistaxis. There would be excessive blood loss during menses, that is menorrhagia would be there in the patient. Post-operatively, there would be excessive bleeding in the patient. Okay, all of these features would be seen, and there would be small bleeding spots which are usually seen around the ankles, because due to gravity, they are more commonly concentrated near the ankle. So these small bleeding spots would be seen, and the non-palpable bleeding spots are usually called as petechiae. Non-palpable bleeding spots are called as petechiae. As I told you earlier also, non-palpable bleeding spots are called as petechiae, but palpable bleeding spots are called as anybody. Palpable bleeding spots are called as if these bleeding spots increase in size, and they would be palpable. Very good. Palpable bleeding spots are called as purpura. Palpable bleeding spots are called as purpura. Okay, please remember this. Okay, so here definitely if there is thrombocytopenia in the patient and there is presence of purpura, definitely the more likely diagnosis would be ITP in the patient. The more likely diagnosis is ITP. So ITP is considered as idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura. Okay, idiopathic or immune thrombocytopenic purpura in the patient. So ITP can either be a acute ITP, whereas it can be a chronic ITP. Acute ITP or chronic ITP. Please tell me, jaldi se. Children में which type of ITP is seen? In children, which type of ITP is seen? Fast. In children, which type of ITP is seen in children? Whether it is acute or chronic ITP. This is how you differentiate. Very good. In children, we will find acute ITP. In children, we will find acute ITP. Whereas in adults, we will find chronic ITP. In adults, we will find chronic ITP. Okay. Acute ITP would have a viral infection as a cause. Okay. Viral infection is the cause of acute ITP. Okay, viral infection is the cause of acute ITP, whereas chronic ITP usually would not be associated with any viral infection. Okay, chronic ITP is not associated with any viral infection. It is more likely to be due to secondary to any other disorder. It is more likely to be secondary to any other disorder. It can be a chronic inflammatory disorder in a patient, or something like leukemia in a patient. Okay, or something like leukemia in a patient can be a cause of chronic ITP. Okay. Or sometimes it would be also idiopathic. If they ask you the most common cause of chronic ITP, answer is idiopathic. Most common cause of chronic ITP, answer is idiopathic, unknown cause. But the other secondary causes can be leukemia or any other inflammatory condition in the patient. Okay, inflammatory condition in the patient. In both of these, definitely the platelet counts would be low. Okay, therefore it is called as thrombocytopenic purpura. Okay, so now please tell me, what is the treatment of choice for acute ITP? What is the treatment of choice for acute ITP in a patient? This was a question in August. What is, they have given a classical case of a child presenting to you with low platelet count and these type of petechiae in a patient which are of rapid onset, that means acute ITP. So what is the treatment of choice? And they had asked you what is the treatment. So please remember that this was the catch in cases of acute ITP. Please remember, this was the catch in cases of acute ITP. If they give a child and there is a feature of ITP, please remember, reassurance should be your best answer. Okay, reassurance should be your best answer, or no treatment should be your answer. No treatment. Why? Because it is a self-limiting condition and it will subside by itself. Okay, so no treatment or reassurance should be your best answer. Here is where they play with you. Okay, whereas in cases of chronic ITP, definitely the first line treatment would be steroids. The drug of choice for chronic ITP would be steroids. Drug of choice for chronic ITP would be steroids. If patient is not responding to steroid, definitely we can give IV IGs. If patient is not responding to steroid, definitely we can give IV immunoglobulins to the patient. No issues with this, anybody? I hope so. And last resort here also would be splenectomy. If spleen is destroying these platelets, vagara, then the last resorts can be splenectomy in the patient. Okay. No issues with this, I hope so now. So here we have spoken about the quantitative loss or quantitative decrease or quantitative defect in the platelet count. Now I'll talk about some qualitative defect in the platelets. Okay, so platelet has two receptors on the surface. Okay, platelets have two receptors on the surface. One is the glycoprotein 1b receptor. One is the glycoprotein 1b receptor, and the other one is the glycoprotein 2b3a receptor. Other one is glycoprotein 2b3a receptor. Now we have two conditions related to it. Whenever there would be some genetic mutation in this patient, there can be a qualitative defect in the platelets, and that would either lead to a condition known as Bernard-Sollier syndrome. Okay, the first one is Bernard-Sollier syndrome, and the second one is known as Glanzmann thrombasthenia. The second one is known as Glanzmann thrombasthenia. Okay, both of these conditions are autosomal recessive. Both of these conditions are autosomal recessive in nature. Okay, both of these conditions are autosomal recessive. What is the problem over here? In Bernard-Sollier syndrome, there is defect in which receptor? Anybody? Sorry. Investigation of choice. Please remember, investigation of choice would just be thrombocytopenia, and you need to rule out the other causes. Okay. So because if it is associated with viral infection, so it can be a clinical along with lab diagnosis. Okay, because as such a single test is not there for ITP patients, and that is why it becomes difficult to diagnose these patients usually. Okay. And in patients of ITP, definitely please remember the BT or in coagulogram, you can see the prothrombin time would be normal, the APTT would be normal, but the BT would be abnormal. Okay, so the bleeding time is prolonged. Normal bleeding time is between 2 to 9 minutes. So the bleeding time in this patients would be prolonged usually. Okay, because there is a platelet defect. So if there is platelet defect, which time is prolonged? It is the bleeding time which is prolonged. So very good. For Bernard-Sollier syndrome, it is defect in the glycoprotein 1b receptor. So in Bernard-Sollier syndrome, there is a defect in the glycoprotein 1b receptor, whereas for Glanzmann thrombasthenia, it is the defect in the glycoprotein 2b3a receptor. It is defect in the glycoprotein 2b3a receptor. So jaldi se revise karte. Bernard-Sollier defect in glycoprotein 1b, Bernard-Sollier defect in glycoprotein 1b, Glanzmann thrombasthenia defect, Glanzmann thrombasthenia defect in glycoprotein 2b3a, Glanzmann thrombasthenia defect in glycoprotein 2b3a. Now apart from this also we can even differentiate the case with the help of a test known as Ristosine aggregation test. Okay, RAT or Ristosine aggregation test is usually negative in cases of Bernard-Sollier syndrome and positive in cases of Glanzmann thrombasthenia. So Ristosine aggregation test. Break. Just let me know if most of you want a break. Chai, you can just grab a chai alongside. You can just keep on listening. Ristosine aggregation test would be negative in Bernard-Sollier syndrome, whereas positive in cases of Glanzmann thrombasthenia. No issues with this. Okay. Sorry, guys. In both these conditions, definitely both of them are platelet defects, so the bleeding time would be prolonged. Both of them are platelet defects, so the bleeding time in both the conditions would be prolonged. If there is a peripheral blood smear, if I take a peripheral blood smear and assess on definite. Okay, I'll just complete platelets. Let me complete platelets, and before starting other conditions, I'll give you a break. Okay, so let's complete platelet and coagulation. I'll complete just coagulation and platelets, and then I'll give you a break. Okay, jaldi se bas. Okay, so on a peripheral blood smear, here normally you can see the platelets are the smallest cells, but here you can see there is giant platelets which are seen. Okay, so if you can see giant platelets, it is a feature of Bernard-Sollier syndrome. If you can see giant platelets on a peripheral blood smear, it is a feature of Bernard-Sollier syndrome, whereas the size of platelets would be normal in cases of Glanzmann thrombasthenia. The size of platelet is normal in cases of Glanzmann thrombasthenia. No issues with this. Important. Okay, yaad rakhna. And now please let me know in the chat box. Small platelets are seen in which condition? Small platelets are seen in which condition? Giant, Bernard-Sollier syndrome. Small platelets, please let me know. If the patient will have small bleeding, if there is deficiency of platelet, definitely. If the patient will have small bleeding spots, then you can give desmopressin to the patient. To prevent any mucosal bleeding, you can give desmopressin to the patient for mild bleeding. But if there is a life-threatening bleed in the patient, post-surgery, if there is a life-threatening bleed in the patient, then you can give cryoprecipitate to the patient. You can give cryoprecipitate to the patient. Okay, no issues with this? No, small platelets, please remember, malaria mein very less likely it is to be seen. More commonly, small platelets are a feature of Wiskott-Aldrich syndrome. More commonly, small platelets are a feature of Wiskott-Aldrich syndrome. Okay, please remember which syndrome? Wiskott-Aldrich syndrome. It is the Wiskott-Aldrich syndrome where small platelets are commonly seen. Okay, so small platelets are seen in conditions of Wiskott-Aldrich syndrome. And Wiskott-Aldrich syndrome is remembered by the mnemonic waiter. It is remembered by the mnemonic waiter. Right? WA goes for Wiskott-Aldrich. I goes for immunodeficiency. I goes for immunodeficiency. I goes for immunodeficiency. T goes for thrombocytopenia. T goes for thrombocytopenia. T goes for decreased platelet count, thrombocytopenia. E goes for eczema in the patient. E goes for eczema in the patient. And R goes for recurrent pyogenic infections. R goes for recurrent pyogenic infections in the patient. Okay? That is waiter usually. Okay, please remember this condition. And it is an X-linked recessive condition, though so more commonly seen in boys. Bernard-Sollier and Glanzmann thrombasthenia, autosomal recessive. But if on peripheral blood smear, small platelets are seen with all these other features and a boy is commonly involved, then it is more likely to be Wiskott-Aldrich syndrome in the patient. Wiskott-Aldrich. No issues with this? Now, please let me know the next question. What is the most common bleeding disorder? Most common inherited bleeding disorder. Most common inherited bleeding disorder. This is the easiest one. Most common inherited bleeding disorder. Don't answer it as hemophilia. Most common inherited bleeding disorder. Most common inherited. Jaldi. सो गए क्या सब? दे रहा हूँ break चाय के लिए. Just I'll complete this. No, most common inherited bleeding disorder is von Willebrand disease. Most common inherited bleeding disorder is von Willebrand disease. As I know, like in cases of von Willebrand disease, there is deficiency or dysfunctional von Willebrand factor. And this von Willebrand factor will help attach the platelet to the endothelium, right? So please remember von Willebrand factor. Von Willebrand factor can be of three types. Type 1 von Willebrand factor is the most common. Type 1 von Willebrand factor is the most common, where there is mild deficiency of von Willebrand factor. Where there is mild deficiency of von Willebrand factor. Type 2 has normal concentration. Type 2 has normal concentration of von Willebrand factor, but the factor which is present is dysfunctional. Okay, so there would be a dysfunctional von Willebrand factor in type 2. And type 3 is the most severe type. Type 3 is the most severe type. Here there would be complete deficiency or complete absence of von Willebrand factor. There would be complete absence or complete deficiency of von Willebrand factor in the patient. Therefore, it is the most severe type. Here also the patient will have the same symptoms as in thrombocytopenia. There would be over here, the patient can have petechiae, purpura, recurrent bleeding, epistaxis, menorrhagia, post-operative bleeding. Okay, all of these features are seen in von Willebrand disease also. Important, please tell me, von Willebrand factor is due to follows which pattern of inheritance? Von Willebrand disease follows which pattern of inheritance? Von Willebrand disease follows which pattern of inheritance? Please let me know. Very good. This is important. It follows autosomal dominant pattern of inheritance. So von Willebrand disease follows autosomal dominant pattern. Von Willebrand disease follows autosomal dominant pattern. Von Willebrand disease follows autosomal dominant pattern. So such kind of things can be asked. Autosomal dominant, X-linked recessive. These are much more common to be asked in the exams. Okay. What would be seen in a coagulogram? So this is different, and that is why I'm telling you coagulogram. Prothrombin time in this patient would be absolutely normal, because prothrombin time reflects the extrinsic pathway, and extrinsic pathway has coagulation factor 7, clotting factor 7, and there is no defect in clotting factor 7. So prothrombin time would be absolutely normal. There is defect in the platelet aggregation, therefore the bleeding time would be prolonged in this patient. Bleeding time is usually prolonged in this patient. What will happen with APTT? Will it remain normal or prolonged? Please let me know. APTT would be normal or prolonged in this patient. APTT would be normal or prolonged in this patient. Very good. Von Willebrand factor, apart from aggregating platelets, it also has one more function, increasing the half-life of factor 8. So if factor 8 half-life decreases, there would be abnormality in the intrinsic pathway. And if intrinsic pathway has some problem, then definitely the APTT would also be prolonged. APTT is also prolonged. So please remember two important things in coagulogram: von Willebrand disease, bleeding time is prolonged, and APTT is prolonged in this patient. Investigation of choice will definitely check the levels of von Willebrand factor. So von Willebrand factor assay is to be done. Okay. Investigation of choice is definitely a von Willebrand factor assay to be done in this patient. Von Willebrand factor assay. And what is the treatment of choice? Anybody? Please let me know the treatment of choice. So if then again there is a mild mucosal bleeding, desmopressin can be given. But if there is severe bleeding in this patient, then definitely we can give cryoprecipitate to the patient, or fresh frozen plasma can be given. Okay, very good. For treatment purposes, mild bleeding ke liye we give desmopressin to the patient. But if there is severe bleeding or life-threatening bleed, then definitely we will give what? Either cryoprecipitate, or we will prefer giving fresh frozen plasma to the patient. Okay, no issues with this. Now, last one, talking about platelets, last thing to be discussed, and then we'll get a break and go for WBCs after that. So, jaldi se batao. This is the easiest one diagnosis. 3-year-old boy coming to you. So, it is more likely a boy. That means a X-linked recessive condition, presents with bilateral knee swelling, easy bruisability, and purpura. Bleeding time and prothrombin time are normal, but the APTT, that is activated partial thromboplastin time, is prolonged. So if APTT is prolonged, as we discussed, that means there is some problem in the intrinsic pathway. That means there is some problem in the intrinsic pathway of coagulation, and intrinsic pathway of coagulation usually involves factor 12, factor 11, factor 9, and factor 8. Okay, there might be some problem in these coagulation factors. Okay, so here on the X-ray also you can see the patient has bilateral knee swelling, and in the joint there is a opacity or a haziness which is seen usually, and this haziness is due to hemarthrosis, that is accumulation of blood in the joints would be seen. So this is a classical case repeated multiple times in exam. Bilateral hemarthrosis they give, or bilateral knee swelling in a child who is mainly a boy, easy bruisability and all the bleeding manifestations. This is more likely to be a diagnosis of hemophilia, more likely a diagnosis of hemophilia in the patient. Hemophilia can either be hemophilia A due to deficiency of clotting factor. Hemophilia A is due to deficiency of clotting factor 8. All of you are right. Hemophilia is due to hemophilia A due to deficiency of clotting factor 8. Hemophilia B due to deficiency of clotting factor 9. Hemophilia B due to clotting factor 9 deficiency. Whereas hemophilia C due to clotting factor 11 deficiency. Hemophilia C due to clotting factor 11 deficiency. 8, 9, 11 yaad rakh lena. Okay, it is not 8, 9, 10, it is 8, 9, 11. Okay, it is an X-linked recessive condition, as I told you. Therefore, females would only be carriers of the disease. Females are only carriers of the disease, whereas boys are affected in this condition. What is the investigation of choice? So the most common type is hemophilia A. Most common type is hemophilia A, clotting factor 8 deficiency. Whereas hemophilia B is also known as royal disease or Christmas disease. Hemophilia B is also known as royal disease or Christmas disease. So this was a question. Christmas diseases. So Christmas disease is due to deficiency of clotting factor 9. This was a straight one-liner. Okay. So what is the investigation of choice? Factor assay. Okay. Factor 8, factor 9, or factor 11 assay should be done. Okay. So you need to check the levels of these factors. So factor assay should be done. Yeah. So whether it is A, B, or C, depending on that, there would be deficiency of factor 8, 9, or 11 respectively. And what is the treatment of choice? If there is factor deficiency, give factors from outside. Okay, so factors are given from outside. That is, factor concentrate is usually given. Okay, we have factor 8 concentrate available, so we usually give factor 8 concentrate to the patient. Okay, factor concentrate is usually given to treat the condition. Okay, important. And if factor 8 concentrate is not available, then the richest source of clotting factors can be given. And what is the richest source of clotting factors? Anybody? One liner, jaldi se. Richest source of clotting factors is. Richest source of clotting factors is. Please let me know. Richest source of clotting factors is. अरे ऐसे कैसे हो गया? Answer in the chat box. Richest source of clotting factors. Important है बहुत. No. Richest source of clotting factors. It is FFP, that is fresh frozen plasma. Richest source of clotting factors is fresh frozen plasma. Richest source of clotting factors is fresh frozen plasma. Okay. Cryoprecipitate also contains clotting factors. It is usually stored at freezing temperatures, but cryoprecipitate mein there is high risk of infection. But the overall most common and the best or the richest source of clotting factors is definitely fresh frozen plasma. It is fresh frozen plasma. Okay, no issues with this. Okay, moving further to WBCs, we'll get a break and we will meet at 5:22. Okay, so exactly at 5:22 I'll be back, guys. ठीक है, so WBC start करके खत्म कर देंगे जल्दी से फिर. $5:25 आ जाओ जल्दी से. And I'll just stop and share the screen again. Please, I request all of you जो भी ये कर रहे हो यार, like scribbling on the screen and all of this. So getting very frank, बच्चों वाली हरकत है यार. This is not the time to do all of these things. If you're not interested, we are not forcing you to join or we are not forcing you to stay. I am here for the people who actually want to study. ठीक है? So please avoid and abstain yourself from scribbling all of these. अगर गलती से हुआ है, then no worries. But अगर गलती से नहीं हुआ, जानबूझ के कर रहे हो, then definitely it's a thing to worry. At this point of time, अगर ये चीजें हो रही है तो.